I'm going to move your leg. If you have any pain, please tell me. Start your examination by checking the tone around the hip, doing circumduction. In the knee, the tone is tested by doing flexion, extension of the knee. Rolling of the knee, looking to the foot. And lifting. Then checking the tone around the ankle by doing circumduction. Now I'm going to check the power. Power around the hip consists of flexion of the hip, push me up, push me down, extension of the hip, push me out, abduction and adduction, push me in. Okay, thank you. Power around the knee, put the knee in the neutral position, which is 90-degree angle. One hand above the knee, and one hand inside. Check for flexion of the knee, push me in. Move both hands, push me out, extension of the knee. Again, push me in please, out. This is for flexion and extension of the knee. For the ankle, again, check for flexion, push me up, and extension. Up, down please, thank you. Reflexes of the lower limb, start with knee reflex. Flex the knee 90-degree with his limb hanging on your arm, his heel just touching the bed. Feel the tendon, percuss while looking to the quadriceps muscle. Ankle flex, you flex the knee 90-degree, dorsiflex, and either the foot, percuss over tendon Achilles. If there is hyperreflexia, you have to check for pathological reflexes, which are the patellar and adductor reflex. Patellar reflex checked by pushing the patella downward and tap over your finger. Adductor reflex checked by pressing the adductor tendon while slightly flexing and abducting the knee, and look for adduction of the side. Now checking for plantar reflex, you have to fix the feet and start scratching from outward, taking the arch of the foot, looking for the first movement of the big toe. Chin from your knee downward. If it is intact, repeat it with closed eye. Would you close your eye, please, and repeat it? The other leg, please. Same on the other leg, please. Close your eye and repeat it, please. لا نفس الناحية بقى وانت مغمض. Okay, thank you. Now moving to the third part of our examination, which is sensation. We start by superficial sensation, pinprick and touch. Can you feel?
Yes.
Same?
Yes.
Would you close your eye, please? Can you feel?
Yes.
Same as above?
Yes.
Here?
Yes.
Same?
Yes.
Here?
Yes.
Same?
Yes.
Here?
Yes.
Same? Testing the sensation in the lower limb done in dermatomal pattern. So this is L4,
Yes.
L5, L3, L2, L1. Pinprick sensation. Can you feel?
Yes.
Same?
Yes.
Would you close your eye, please?
Yes.
Can you feel?
Yes.
Same as above? Can you feel?
Yes.
Same as above?
Yes.
Can you feel?
Yes.
Same?
Yes.
Same?
Yes.
Thank you. Now I'm going to test the deep sensation which is vibration and joint position sense. Please, if you feel vibration, tell me. Can you feel a vibration?
Yes.
See?
Yes.
Close your eye. Can you feel?
Yes.
Same as above?
Yes.
Can you feel?
Yes.
Same as above?
Yes.
Okay. If you cannot feel, you have to move with the tuning fork upward to the medial malleolus, tibial tuberosity, anterior superior iliac spine, you have to check it. Then xiphoid, manubrium, clavicle, mastoid. Stop where the patient feels as above. Testing for the joint position. I'm going to move your toe. This is up. This is down. Would you close your eye, please, and tell me where is your toe?
Down.
Thank you. Again, this is up and this is down.
Up.
And first thing I will do flexion of the hip, abduction of the hip. I will do them for you. I'll ask you when to do them. And abduction of the hip. So the first thing, I put my hand as far from the hip as possible and ask him to bend his leg. Yeah. Okay, so that's good. So that's 5. And here, that's also 5. Now, I put my hand underneath him and ask him to press. Don't let me take my hand. So this is quite good extension, and I will do the same with the other thigh. For the abduction, I come and hold, put his legs beside each other and ask him to push apart. So he's pushing, and the other way around, push inside, he's pushing inside, so it's quite good. The next step is to test for the power of the knee, and the knee has 2 movements, extension and flexion. And usually I come towards the patient and ask him to bend his knee, and I hold the ankle and ask him, or maybe if I come here it would be better. So I put my hand here and ask him to pull your ankle, that's good, and push me away, so that he pushed me away. That's quite nice. Let's repeat it with the other one. Pull towards you, push towards me, so that's good. So now we know that his knees are quite good. Now if we come to test the foot has 4 movements that need to be tested. One of them is dorsiflexion, one of them is plantarflexion, eversion, and inversion. And what we will do is put the hand here and ask him to do dorsiflexion, pull towards you, so that's good. Push me down, that's quite good. And then can you turn your hand, your leg out, foot out, that's good. And this one, can you turn the foot out? All right, now can you turn it in? That's good. And then this one, that's good. So the power of this patient is quite normal, whether upper limbs or the lower limbs. Sometimes we need to test fine changes in the power, subtle changes in the power. And we do this in the upper limbs by a test.
So we're going to start with the testing for the anterior and posterior cruciate ligaments. So I'm going to have you bend your knee to approximately 90 degrees and plant your foot on the table. I now need to stabilize this foot. So I'm going to use a little bit of my own body weight to stabilize that foot. So now with my hands on the knee, I'm going to try and translate the knee forward, testing the anterior cruciate ligament, and try and pull and see if I can translate it forward. And now do the same thing, pushing backwards to test the posterior cruciate ligament. All right, and he has no instability. So now we're going to use the Lachman test. The Lachman is another test for the anterior cruciate ligament. I'm going to bend his knee to approximately 30 degrees. I'm going to stabilize the femur and attempt to pull the tibia forward on the femur. And again, he has no instability in the knee, so there's no anterior translation. Now we need to do varus and valgus stress of the knee to test the medial collateral and lateral collateral ligaments. Now, this needs to be done at approximately 30 degrees, and the leg can be kind of heavy and sometimes hard to hold on your own. So you can use the table to support it for you. So I'm going to move your leg off to the side, so it's hanging off the table a little bit, and have the knee bent at 90 degrees. If I want to test for valgus stress for the medial collateral ligament, what I'm going to do is place my hand on the outside of his thigh and the inside of his lower leg and push. Try and push the lower leg outward. For varus stress for the lateral collateral ligament, we'll do the opposite. Put my hand on the outer side of his lower leg and the medial side of his thigh and try and push it inward. And again, he has no instability, so there's no movement or pain. So for this test, we want to bend the leg. And again, you're going to let me do all the movements of your leg. We're going to bend his knee fully. I'm going to place my fingers on the joint line of the leg. I'm testing the medial meniscus. I'm going to put pressure on the medial joint line. I'm then going to grab onto his foot so that my thumb is on the same side as what I'm testing. So my thumb is now on the medial side of the knee. I want to turn his tibia outwards, which turns his heel inwards a little bit. And with varus stress on his knee, I'm going to sweep his leg outward. So I am straightening and sweeping his leg medially. Bending it. And that puts pressure on that medial meniscus. A positive test would be pain or clicking at that medial side. If I'm testing the lateral meniscus, I'm going to move my lower hand so that my thumb is on the outside of the heel. I am now going to put pressure on the lateral side of his knee at the joint line at the level of the lateral meniscus. I'm going to turn his tibia inward or his heel outward, and then with valgus stress on the knee, again, I'm going to sweep the leg out, only this time sweep the leg outward laterally. So sweep the leg out and straighten it, and then back. And out, and then back. And again, a positive test there would be pain or clicking in the lateral side of the knee. So finally, we want to be able to assess for an effusion of the knee. If you suspect a large effusion, you can do a patellar ballottement. So for that, you want to sort of milk downwards from the quadriceps to bring any of the fluid down, and then press on the patella. You'll feel the patella floating on the fluid wave. He does not have an effusion, so he does not have that. If you suspect a small effusion, you want to milk superiorly from the medial side of the knee to bring any fluid upwards, and then push laterally, and you might see a small fluid wave pushing out onto the medial surface of the knee. Again, he doesn't have an effusion, so we do not see a positive test there. So I'm going to ask you to bend and bring your knee up towards your chest, and then just kind of relax. So the first thing I'm going to palpate is the the greater trochanter of the femur, which is on the lateral aspect of the hip. Next, I want to palpate essentially what's your sit bone, which is the ischial tuberosity, which is deep here in the muscle. So I'm going to palpate deep under here. So palpating for the ischial tuberosity. And then finally, I want to palpate along the sacroiliac joint over here. You're going to want to make sure you do that on both hips and have the patient roll the opposite direction to do the opposite hip. Well, I've got you on this side. I'm going to check the range of motion partially of your hip. So I'm going to have you straighten your leg, and I'm going to stabilize your hip for you. And what I'm going to do is ask you to take this leg and move it behind you as far as you can for testing for extension, and you can bring it back. Now, if the patient has any abnormalities in the active range of motion, I can test it passively. So I'm going to take your leg and do it for you, and then bring it back. All right. For the remainder, I'm going to ask you to roll over onto your back. So we want to check active range of motion of the hip. So I'm going to start with hip flexion. So what I want you to do is take this leg and bend it up towards, so you bring your knee to your chest as far as it'll go. Okay, and relax. All right, now we need to test adduction. So what I'm going to ask you to do is take this leg and sweep it out to the side as far as you can make it go. And now bring it back, and now cross it over as far as you can cross it. All right, so now again, if there was any abnormalities, I would test this passively. So I'm going to move your leg for you. So take your leg and bend it as far as it will go. Test for adduction by bringing it, abduction by bringing it out, and then adduction by crossing it over. All right, and make sure that the patient is allowing you to do all of the motion and they're not doing the motion for you. Finally, we're going to test internal and external rotation of the hip. This is typically done only passively. So I'm going to lift your hip up for you, bring the hip to 90 degrees with the knee bent at approximately 90 degrees. All right. So for what we're talking about here is motion of the hip. And so for motion of the hip, internal rotation is moving the foot outwards, and external rotation is turning the foot inwards. And relax. And then again, make sure you test that on both sides. So now we're going to evaluate the knee joint. So again, just with any other exam, it's going to start with a general inspection. We're going to want to inspect the knee primarily at 90 degrees is the best way to do the inspection and palpation. So I'm going to have you bend your leg for me and put it in that position. I want to look at both knees. I'm going to have you bend both knees for me for the moment. I want to look to see, is there any evidence of asymmetry? Is there any redness or swelling? When I'm palpating the knee itself, I need to make sure that I'm working along the joint line as well as along the ligaments that attach it. So I'm going to start superiorly with the quadriceps tendon, palpate down to the patella. From the patella, I can palpate the patellar tendon down to the tibial tubercle. From there, I can assess the joint line. So I can feel the tibial plateau as I come across the joint line. And as I move laterally, I can palpate the fibular head. You also want to pay special attention to the medial and lateral coligaments. So on the lateral side, the lateral coligament up here at the medial lateral femoral condyle, and then I'll palpate down to the fibular head. So in this knee, we have the medial collateral ligament. So we'll start off with the medial femoral condyle, palpating down along the joint line to where it attaches to the tibial plateau, and then finally over to the anserine bursa on the anterior aspect of the knee. So range of motion of the knee, it's best to do this with the patient lying down so you can get full range of motion of the knee. So you want to, again, start with active range of motion. So I'm going to ask you to take your knee and bend it as far as you can, putting your heel as close as you can to your backside. And now bring your leg out and straighten your knee. All right. If there's any abnormalities in this, I want you to do the same thing with this knee. So I can compare side to side. Bend it as far as you can, and now straighten it. If there's any abnormalities in this, we want to test this passively. So I'm going to move the leg for you, and you just let me move the leg. So bend it as far as it'll go, and then straighten it all the way. So for the evaluation of the ankle, we're going to start with the general inspection. So again, remember you want to do this on both ankles. But again, we want to inspect the ankle from all sides, again, looking for any obvious deformities, redness, or swelling. For palpation of the joint line markers, we're going to start with palpation of the tibio-talar joint. We want to be able to palpate both the lateral malleolus as well as the medial malleolus. Moving down onto the heel, we want a general palpation of the calcaneus, but also the calcaneal tubercle where the Achilles tendon attaches, and then upwards along the Achilles tendon. So now we want to talk about range of motion. I'm going to have you relax your foot a little bit for me. So what I want you to do is start by pointing your toes up towards the sky for dorsiflexion. Now point your toes towards the ground for plantar flexion. Now I want you to bring your foot inward for inversion and bring your foot out for eversion. So again, any abnormalities in the active range of motion, we'll do it passively. So I'm going to take your foot and try and move it up as far as I can, and now bring it down, move it inwards, move it outwards. And again, for eversion and inversion, there's very little range of motion. Finally, for the inspection of the foot, we want to make sure that you get both the dorsal surface and the plantar surface of the foot. So we'll inspect the dorsal surface of the foot and palpate at the metatarsal phalangeal joints. Now I'm going to lift the foot upwards so I can look at the inferior surface of the foot and palpate at the base of the forefoot. If there's any pain or specific abnormalities, you can palpate the individual interphalangeal joints on the foot, but it's not done as part of a general.
Afternoon, Barry. How are you going?
Oh, good afternoon. How?
I'm good. And are you comfortable where you are?
Yes.
Pillows okay?
Yes, a little bit.
All right, lovely. Now, we've had a little bit of a look at your gait, and one of the things that we noticed when you're walking is that when you're walking, your heel's not always going right down onto the ground, especially with your right leg.
Yeah.
So what I'd like to do is have a little look and see what kind of things could be contributing to that.
Yeah.
Okay. So the first thing I'm going to do is just get you to pull your toes right back for me as far as you can. So leaving your legs flat on the ground for me. That's it. Pulling your toes back. Can you point your toes down to the floor for me? All the way down. Very good. Now this time, I want you to bring your toes up towards your head as hard as you can. Don't let me move you. Don't let me move your feet. Wonderful. And this time, pushing your toes right down to the ground into my hands. Wonderful. Good. Okay. Now, just there, I was just testing the strength to see how the strength is in your ankles there. The next thing I'm just going to have a look at is the range of movement you've got in your ankle here.
Yeah.
Okay, so again, I'm just going to get you to pull your toes up towards your head. That's it. And just comparing that to the other side there. And that's it, and pointing your toes back down to the ground for me. All right. Now, I'm just going to pop this roll under your knee. Okay. And it's just under the one leg at the moment. And I'll get you to pull your ankle back for me as far as you can. Just leave your heel on the bed for me and pull your ankle back and back down to the ground. Point your toes down. Okay. And I'm going to swap it over to your other leg. Okay, and again, toes up towards your head. Good. And pointing your toes down. Well done. Okay. Now, this time I'm going to have a bit of a look at the sensation in your legs. So, can you feel this? Can you feel me touching you there?
Yeah, just, yeah.
On that side?
Yeah.
And down here?
Yeah. Just.
Okay. So, I'm going to get you to close your eyes for me. And when you feel me touch you, I want you to say yes. Okay? So, closing your eyes for me.
Left. Left. Left ankle. Left bottom. Other one. Right.
So just say yes or no, Barry.
No.
If you feel me.
Yes. 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 Yes.
Okay. Thank you. You can open your eyes now. Actually, no, I don't need that one. Okay, so the next thing I'm going to test is just to see whether you know where your ankle is moving in space. So what I'm going to do is I'm going to position your left foot in a position, and I want you to try and match it up with your other foot. Okay?
Yeah.
So for example, if I am bringing your foot back, just relax for me. Yep. So let me move your foot for you, and I want to see if you can match the same thing with your other leg. You can match the same movement. Oh, it's all right, I don't have a roll for both. Okay. So closing your eyes for me and matching it up for me. Okay, just relax for me on this leg. Okay, great. Now, the last thing I'd like you to do, you can open your eyes now. I'll get you to sit up onto the edge of the bed for me, and I'm just going to test your reflexes in your legs, okay?
Okay.
All right? Okay. All right, Barry, so the next thing I'm going to do is I'm just going to have a look at how your muscles are contracting and relaxing. So I'm just going to do a quick movement with your ankle to see how we go, all right?
All right.
So when you're ready, so just relaxing your ankle for me. Comfortable? It's all right?
Yes. Yeah.
Okay. And just on the other side, just relaxing this foot for me. All right, now I can get you to sit up onto the edge of the bed for me. Right to go, Dave.
What's it, a drumstick?
So I'm just going to test the reflexes in your leg here.
Yes.
Okay, so I'm just going to do one up here for me. Might jump your leg a little bit.
Yes.
The exam begins by establishing that there's full knee extension and it's symmetric. And then I'll do the whole exam on the uninjured knee. Check for stability to anterior, posterior, to varus and valgus stresses. And then check the menisci with the McMurray's maneuver. I'll then go to the injured knee, the operative knee in this case, and do a Lockman's exam. Notice the excursion of the tibia anteriorly on the femur because of the deficient anterior cruciate ligament. Then I'll do a pivot shift exam. So with loading, a valgus stress, the tibia goes from subluxated to reduced. Subluxated to reduced with a clunk. We'll see two views of this. Again, I'm internally rotating, loading with a valgus stress. It goes from subluxated to reduced. Here's a repeat of the Lockman's, the pivot shift, and then I'll check for stability to varus and valgus stress in full extension, and then about 20 degrees in knee flexion. Check a posterior drawer, and then see if there's any clicking or clunking with McMurray's maneuver. The Lockman's is repeated. Notice the increased excursion of the tibia on the femur. The pivot shift shows the tibia going from subluxated to reduced with knee flexion. Stresses are placed to the knee in varus and valgus, varus and valgus with mild flexion, and then a posterior drawer shows no increased excursion. Flexion, rotation, feeling for a clunk, tests for meniscus pathology.
To check deep tendon reflexes, I distract the patient by having them hook flexed fingers while I test the reflexes. The knee jerk tests L2, 3, and 4, but primarily L4. The ankle jerk tests S1. L5 is the most common lumbar radiculopathy we'll see in practice, but it has no measurable deep tendon reflex, which brings us to strength testing. Strength testing started earlier in my exam when the patient was asked to walk on their toes, which tests S1 motor strength, and walk on their heels to test L4, L5 motor strength. While the patient is sitting, strength testing starts with the feet and great toes. Again, L5 has no deep tendon reflex, and its only autonomous motor is the extensor hallucis longus, which is tested by opposing dorsiflexion of the great toe. In patients with weakness, we need to differentiate if the patient is weak due to their pain or a neuromuscular deficit. Pain is a common cause of apparent hip flexor weakness, but is not typically the cause of weakness on examination of their feet and great toes. Besides strength and reflex testing, we often perform the straight leg raise. I perform the sitting straight leg raise while distracting the patient with my reflex exam. The sitting straight leg raise is much easier to perform and interpret correctly. A patient with a positive sitting straight leg raise will lean back and not let you straighten their leg. If the sitting straight leg raise is negative, but the straight leg raise supine is markedly positive within 20 to 30 degrees, it is documented as an inconsistency. Finally, the patient must relax and not engage the muscles. The third point about the straight leg raise is that the examiner, not the patient, lifts the leg during the maneuver. If the sciatic pain occurs, stop, lower the limb slightly, and dorsiflex the foot. If the sciatic pain is not reproduced, the lower extremity pain on exam is likely due to hamstring muscle problems rather than a nerve impingement. I observe the patient transfer from supine to sitting, and typically they turn on their side to sit up to avoid exacerbation of the
shin test. We will ask our subject to lie in a couch, ask him to place the heel of his opposite knee, slide in downwards along the shin to ankle, then lift it making a semicircle, place it again on the knee and repeat this procedure. अब आपने अपनी ये जो राइट हील है ना, इसको अपने लेफ्ट नी के साथ लगाना है और फिर आपने इसको पूरा नीचे लेके आना है और ये आपने बार बार करना है। अब आप करें। करते रहे। Now we will perform the knee jerk reflex. We will ask the subject to sit on a stool with his lower limbs hanging freely, and we will perform our test. We will expose the knee of the patient and we will strike on the patellar tendon. Normally there should be extension of the leg due to contraction of the quadriceps femoris muscle.
Okay. Now we will check dorsiflexion of foot, and then after dorsiflexion we will check plantar flexion of foot. ओके आपका ये है कि आपने ना अपना पाँव जो है अपनी तरफ लेके आना है, ठीक है, और मैं पीछे को जरूर करूँगा। ओके, अभी इनकी प्लांटर फ्लेक्शन ये नीचे को करेंगे आप, मैं ऊपर को। ओके ओके, अब हम एक्सटेंसर ऑफ नी जॉइंट चेक करेंगे। ऐसा है कि आपने अपने ये जो है ना इसको सीधा करना है टांग को, ठीक है, और मैं जो लगाऊंगा आपको ये सब, ठीक है, आपने मेरे अपोज करना है और टांग सीधी करनी है, ठीक है। चलें, ओके, ये एक्सटेंसर ऑफ नी है इनका नॉर्मल। अभी ये है कि इनका फ्लेक्सर ऑफ नी जॉइंट चेक करना है, ठीक है। ऐसा है कि मैं अभी ये टांग ऊपर उठाऊंगा, ठीक है। अब आपने अपने ये टांग मोड़नी है और मैंने आपको मोड़ने नहीं देनी, ठीक है। चलें, ओके, ये इनके था फ्लेक्सर ऑफ नी जॉइंट। फ्लेक्सर ऑफ थाई के लिए ऐसा है कि आप अपनी जो है ना टांग अच्छा फ्लेक्सर ऑफ थाइज अब चेक करना है, ठीक है। ऐसा है कि मैं आपने अपनी टांग ऊपर उठानी है और मैं जोर लगाऊंगा नीचे को, ठीक है। इसे हमारा फ्लेक्सर ऑफ थाई चेक होगा। चलें, ओके, ये फ्लेक्सर ऑफ थाई था, ये जोर ऊपर को लगा रहे थे लेकिन मेरी तरफ से जोर नीचे की तरफ था, इसका मतलब कि इनकी थाई का फ्लेक्सर चेक होगा। ओके, अब हम अब हम ऐसा है कि इनकी एब्डक्टर ऑफ लेग चेक करेंगे। वो उसका तरीका ये है कि मैं आपकी टांगें पकड़ूंगा, ठीक है, लेकिन आपने इनको खोलने की ट्राई करनी है, ठीक है। चलें, ओके, अब है एडक्टर्स हमें चेक करने हैं, ठीक है। उसके लिए ऐसा है कि ये मैं आपकी टांगें ऐसा खोल रहा हूँ, आपने इनको मिड लाइन में लेके आना है, अपनी तरफ लेके आना है, ठीक है। इनको जोड़ना है आपस में और मैं जोर लगाऊंगा इस तरफ, ठीक है। चलें, ओके,